Good morning. Please take a seat. I am formally initiating this session. For the benefit of the observing trainees sitting in with us today, and yes, I'm speaking directly to you, pay close attention. This is a Level 7 academic review for the FRCS Exit Exam. We are focusing entirely on gastrointestinal neuroendocrine tumors, or GI NETs.
Right. Good morning. Thank you.
To be clear, candidate, I expect your answers today to be exhaustive, methodical, and clearly articulated. There is no room for conversational fluff or casual banter here. This is a rigorous intellectual stress test. We will interrogate etiology, diagnostic hierarchies, the evidence base, operative technicalities, and we will conclude with a high-pressure mock viva. Are you prepared?
I am. Yes, absolutely.
Excellent. Let us begin with Section 1, Etiology and Applied Anatomy. I want you to start by delineating the embryological origins of the GI tract. How exactly do these origins dictate the location and the behavior of neuroendocrine neoplasms?
Right. Well, to understand the behavior, we have to look at the enterochromaffin cells. The gastrointestinal tract is embryologically divided into three distinct territories. You have the foregut, the midgut, and the hindgut.
Be specific about the anatomical boundaries for the trainee.
Of course, the foregut extends from the oropharynx down to the ampulla of Vater in the duodenum, and it includes the liver and pancreas. Tumors here often present with very distinct hormonal profiles. For example, gastrin hypersecretion leading to peptic ulcer disease.
Right. And the midgut. This is where we see the most dramatic presentations.
Yes, exactly. The midgut runs from the distal half of the duodenum down to the proximal two-thirds of the transverse colon. These midgut nets, particularly in the jejunum and terminal ileum, are the classic high-volume serotonin producers. Because of their evolutionary roots, they are hardwired to synthesize and store serotonin, which makes them the primary culprits behind carcinoid syndrome.
And the hindgut.
The hindgut, so distal third of the transverse colon down to the upper anal canal, typically harbors non-secretory tumors.
Yeah.
They are mostly discovered entirely by accident, usually during a routine screening colonoscopy.
Let us zoom in from gross anatomy to molecular pathology. The 2019 WHO and the 2017 AJCC classifications completely rewrote the rulebook here. You must unpack the distinction between well-differentiated neuroendocrine tumors, NETs, and poorly differentiated neuroendocrine carcinomas, NECs.
It was a massive paradigm shift. The fundamental division now is based on cellular differentiation and histological maturity. A well-differentiated NET possesses cells that actually look like normal neuroendocrine cells under a microscope. They have uniform nuclei, that classic salt and pepper chromatin pattern, and they strongly express markers like synaptophysin.
And the carcinomas.
Poorly differentiated NECs are completely chaotic. They show marked nuclear atypia, massive necrosis, and incredibly rapid proliferation. They don't look like endocrine cells at all.
I want the molecular pathophysiology. What are the specific mutational drivers for each?
Right, so well-differentiated NETs frequently harbor mutations in the MEN1 gene, a classic tumor suppressor, as well as DAXX and ATRX mutations.
Explain the significance of DAX and ATRX to the trainee.
Yes, DAXX and ATRX are intimately involved in chromatin remodeling and telomere maintenance. When those mutate, the cell essentially achieves rogue immortality, but crucially, it maintains its well-differentiated architecture.
Contrast that with the NECs.
In stark contrast, poorly differentiated NECs are driven by catastrophic mutations, typically seen in aggressive adenocarcinomas. We were talking about the profound loss of tumor suppressor genes like TP53, the guardian of the genome, or the RB1 mutation. Biologically, these are entirely divergent diseases.
This brings us to a major historical pitfall. I want you to explain the Ki-67 proliferation index and the mitotic count criteria, and specifically clarify the confusion surrounding the G3 classification.
Yes, this is a critical point. The grading relies on the mitotic count and the Ki-67 index, which is simply the percentage of cells actively preparing to divide. A G1 tumor is indolent, with a Ki-67 of less than 3%. A G2 is between 3 and 20%.
And the G3? Historically, anything over 20% was automatically deemed a poorly differentiated carcinoma.
Exactly, and that was a dangerous assumption. The 2019 WHO update importantly separated them. We now recognize the well-differentiated NET G3. These tumors have a Ki-67 index greater than 20%, usually between 21 and 55%. But they retain that organized, well-differentiated morphology.
So they are fast-growing but still structurally intact.
Precisely. And more importantly, they retain the DACX-ATRX or MN1 mutational profile. They do not have the TP53 mutations of a true carcinoma.
Why does this matter for the patient clinically?
Because it changes the entire treatment trajectory. A well-differentiated NET G3 responds to traditional neuroendocrine therapies, or targeted therapies. A true poorly differentiated NEC, which usually has a Chi-67 well above 55%, requires highly toxic platinum-based chemotherapy. If you mix them up, you give the wrong treatment.
Acceptable. Let us debate the pathophysiology of the desmoplastic reaction. This is characteristic of midgut nets. Why does this profound mesenteric fibrosis occur, and how does it lead to bowel ischemia?
The desmoplastic reaction is a hallmark of terminal ileum nets. These tumors hypersecrete serotonin, but they also pump out a cocktail of fibrogenic growth factors like TGF-beta. When these drain into the mesenteric venous system, they trigger an intense, localized fibrotic response in the mesenteric fat.
What does that physically look like in the abdomen?
It forms a dense, retractile, almost concrete-like mass in the root of the mesentery. Mechanically, this foreshortens the mesentery and tethers the small bowel, causing physical obstruction.
And the vascular consequence?
That is the most dangerous part. The fibrotic mass completely envelops and strangulates the superior mesenteric artery and vein. You get severe venous engorgement because blood can't drain, followed by arterial insufficiency. Ultimately, this leads to profound bowel ischemia,
Which provides a natural transition to Section 2, the Diagnostic Hierarchy. We will spend the next 15 minutes here, review the clinical presentation. We frequently see a 5 to 7 year diagnostic delay. Why?
The delay occurs because the early symptoms are notoriously vague. Most GI nets are initially non-functioning. The patient presents with intermittent abdominal pain, bloating, or changes in bowel habits. It perfectly mimics irritable bowel syndrome. They are often just incidental findings during a scan for something else.
But approximately 20% present acutely. What are the signs?
In the acute setting, they present to the emergency department with signs of a high-grade mechanical small bowel obstruction or acute mesenteric ischemia driven by that desmoplastic mass we just discussed. They'll have a rigid, guarded acute abdomen requiring urgent surgical evaluation.
Let us move to systemic symptoms. Detail carcinoid syndrome. And specifically, I want the mechanism behind Hettinger syndrome.
Right. Carcinoid syndrome typically only occurs once a midgut net has metastasized to the liver.
Why is liver metastasis the prerequisite?
Because of hepatic first-pass metabolism. Normally, serotonin draining from the bowel goes to the liver via the portal vein, where monoamine oxidase enzymes destroy it. But once there are metastatic nodules in the liver parenchyma, they dump serotonin directly into the hepatic veins, bypassing the filter and hitting the systemic circulation.
What are the clinical hallmarks?
Episodic, dry, cutaneous flushing of the face and neck, driven by tachykinins, and profound secretory diarrhea, sometimes 20 watery movements a day, mediated by serotonin's effect on intestinal motility.
Now, address Hettinger syndrome, the right-sided heart disease.
Prolonged exposure to high serotonin levels causes the deposition of thick, fibrous plaques on the endocardial surfaces of the tricuspid and pulmonary valves. They become rigid, leading to tricuspid regurgitation and eventual right-sided heart failure.
Why does it spare the left side of the heart?
Because as the blood passes through the pulmonary circulation, the endothelial cells in the lungs metabolize the vasoactive peptides. The lungs act as a secondary filter, protecting the left heart.
Very well. Let us interrogate the biochemical evaluation, detail the utility and the severe limitations of chromogranin A, or CGA, and the fasting 24-hour urine 5-HIAA. Start with 5-HIAA.
Well, 5-HIAA is the primary metabolic breakdown product of serotonin. A fasting 24-hour urine collection is highly specific for diagnosing functional midgut nets.
But what are the logistical pitfalls? The trainee needs to know why this test comes back falsely elevated.
The dietary restrictions are incredibly strict. The patient absolutely must avoid foods high in serotonin precursors for days prior. If they eat bananas, avocados, walnuts, or pineapples, their 5-HIAA will spike, causing a false positive.
And what about chromogranin A? It is broadly used, but false positives are rampant. Explain the physiological cascade that causes proton pump inhibitors to falsely elevate CGA.
Yes. CGA is a glycoprotein secreted by almost all neuroendocrine cells. It's useful for tracking tumor burden, but its specificity is poor. Proton pump inhibitors, PPIs, shut down stomach acid, inducing achlorhydria.
Go on.
The stomach loses its acid-negative feedback loop. So the antral G cells massively hypersecrete gastrin to try and stimulate acid production. This hypergastrinemia constantly stimulates the normal enterochromaffin-like cells in the stomach lining, causing them to undergo hyperplasia. As they multiply, they dump huge amounts of CGA into the blood.
So a patient on heartburn medication looks like they have a neuroendocrine tumor.
Exactly. And chronic atrophic gastritis does the exact same thing. Also, CGA is cleared by the kidneys, so any renal insufficiency will artificially elevate it.
Let us move to imaging modalities. What is the hierarchy here? Explain the triple-phase CT protocol.
We must use a triple-phase CT of the thorax, abdomen, and pelvis. We need images during the non-contrast, early arterial, and portal venous phases.
Why early arterial? What are you looking for?
GI nets and their liver metastases are highly hypervascular. During the early arterial phase, they rapidly absorb the contrast dye and exhibit intense enhancement against the dark surrounding tissue.
And what is the trap if a junior doctor only orders a standard venous phase scan?
By the time the scan reaches the portal venous phase seconds later, the contrast is washed out. The tumor becomes isodence. It blends in with the normal liver parenchyma. You will completely miss metastatic disease if you only use a venous phase.
For hepatic metastases under 1 centimeter, what is the superior modality?
Liver-specific MRI protocols using diffusion-weighted sequences and hepatocyte-specific contrast agents. It is unparalleled for mapping exact tumor burden prior to liver surgery.
Now, I require specific critique. I want you to aggressively analyze the role of PET-CT. Compare 68 gallium dotatate, the SS-PATE, against standard FDG-PET.
Right. SS-PATE is the absolute gold standard for staging well-differentiated G1 and G2 nets. It uses a radio-labeled somatostatin analog that binds to somatostatin receptor subtype 2, which these tumors vastly overexpress. It creates a highly sensitive 3D map of the disease.
But it has severe pitfalls. What causes false positives on an SSA-PATE?
Somatostatin receptors are also expressed by activated macrophages and lymphocytes. So any area of active inflammation, a healing surgical incision, tuberculosis, or inflammatory bowel disease will show intense radiotracer uptake and mimic a metastasis.
Address the physiological variant regarding the thymus.
Yes, thymic hyperplasia. Normal or hyperplastic thymic tissue naturally expresses high levels of somatostatin receptors. On an SA-PATE, it will present as an intensely avid mass in the anterior mediastinum.
And what is the catastrophic surgical error here?
If a surgeon assumes that glowing spot is a metastasis without correlating it with anatomical imaging, they might perform a sternotomy, cracking the chest open to remove a perfectly benign thymus gland. It would be a massive, unnecessary morbidity.
And when do we deploy FDG?
FDG PET measures glucose metabolism. Low-grade nets grow too slowly to be glucose-avid, so it's useless there. But as tumors de-differentiate into high-grade G3 nets, or true NECs, they lose somatostatin receptors and upregulate glucose metabolism. For those aggressive tumors, FDG-PET is the modality of choice.
Thorough. This brings us to Section 3, the evidence base. We will spend 15 minutes establishing what the evidence dictates we actually do with this diagnostic data. Review the ENET's 2023 guidelines. There has been a major shift regarding obstructing midgut nets.
Historically, the standard of care for an obstructing midgut net was an immediate emergency laparotomy. The new guidelines, however, advocate for a conservative, step-up approach whenever physiologically permissible.
Why? What is the danger of an emergency laparotomy at 2 in the morning?
In an emergency setting, the patient is completely unstaged. You do not have an MRI or an SSA PET. You might perform a massive bowel resection, only to find out later they have unresectable liver metastases. Furthermore, surgeons operating out of hours often miss multifocal primary disease or are unprepared for that massive encasing mesenteric root mass.
So what is the current standard?
We aggressively resuscitate, correct electrolytes, and decompress the bowel with a nasogastric tube. This often settles the acute obstruction. It buys us a crucial window to complete full staging and discuss the case at an ENET Center of Excellence multidisciplinary team meeting. This allows for a planned elective resection.
Unless there's peritonitis, obviously.
Of course, frank perforation or dead bowel mandates immediate surgery.
Let us examine gastric nets. How does the evidence dictate the management of type I versus type 3?
The etiology dictates the treatment. Type I gastric nets are driven by chronic autoimmune atrophic gastritis. The resulting eclohydria causes hypergastrinemia, which drives multiple small low-grade tumors.
Because they are hormonally driven, they are indolent. What does ENETS recommend?
A step-up endoscopic approach. Lesions under 1 centimeter are surveyed. Lesions between 1 and 2 centimeters undergo endoscopic mucosal resection, or EMR. Formal surgery is rarely indicated unless the tumor is large or deeply invasive.
Contrast that with type 3.
Type 3 tumors are sporadic. They are not driven by gastrin, they are driven by internal mutations. They are biologically aggressive and highly prone to early lymph node metastasis. For these, the evidence mandates aggressive surgery. A partial or total gastrectomy with a formal D2 lymphadenectomy, just like an adenocarcinoma.
Briefly discuss the evidence for medical management. What is the role of somatostatin analogs, and what did PROMID and Clarinet prove?
SSAs like octreotide not only control the secretory symptoms, but the PROMIT and clarinet trials provided level 1 evidence that they significantly prolong progression-free survival by exerting an anti-proliferative effect. They basically put the tumor to sleep.
And if the disease progresses, what did Radiant-4 show?
Radiant-4 demonstrated the efficacy of everolimus, an mTOR pathway inhibitor, which improved progression-free survival in non-functional GI nets.
I want you to discuss PRRT. What is the mechanism and what is the landmark trial?
Peptide receptor radionuclide therapy. We use lutetium-177 dotatate. It's a targeted radiation therapy. The dotatate binds to the somatostatin receptors on the cancer cell, gets internalized, and the lutetium-177 delivers a lethal dose of beta radiation directly to the tumor DNA. The NETTER-1 trial proved this drastically improves both progression-free and overall survival in advanced midgut nets.
Let us test your clinical judgment with a scenario. You are consulted on an 85-year-old male. He is highly comorbid severe congestive heart failure, home oxygen for COPD. During a routine endoscopy for mild anemia, they incidentally find a 1.2 centimeter G1 net in the duodenal bulb. Endoscopic ultrasound shows it is superficial. CT shows no spread. Use the ENETS guidelines to justify your management.
Right. Well, we are treating the patient, not just the scan. According to ETETS, a 1.2 centimeter duodenal net does have a small risk of lymphatic spread. However, a formal surgical resection here would require a transduodenal local resection or even a Whipple procedure.
And in this specific patient?
In an 85-year-old with severe heart failure and COPD, the physiological insult of general anesthesia and a major abdominal operation carries an unacceptably high perioperative mortality rate.
What about endoscopic resection?
The duodenal wall is incredibly thin. EMR carries a high risk of delayed bleeding or perforation, which would force an emergency laparotomy anyway.
So what is your decision?
A watch-and-wait approach with minimal surveillance. The biology of a G1 net is highly indolent. Given his severe comorbidities, he is far more likely to die with this tiny tumor than from it. The morbidity of a radical resection is completely unjustified here.
Correct. Assuming the evidence points to surgery in a fit patient, let us move to Section 4. Operative technicalities. Talk me through the gold standard operative execution. Start with the stomach and duodenum.
For a small type 3 gastric net, a laparoscopic wedge resection with nodal sampling is appropriate. For larger lesions or confirmed nodal spread, a formal subtotal or total gastrectomy with D2 lymphadenectomy is required.
And for the duodenum?
For non-ampullary tumors over 10 millimeters, a transduodenal full-thickness local resection.
But if the lesion is right on the ampulla of Vater and measures 16 millimeters?
Then local resection risks destroying the bile and pancreatic ducts. The gold standard there is a formal pancreatoduodenectomy, the Whipple procedure.
Move to the midgut. Jejunal tumors. What is the absolute non-negotiable requirement during abdominal exploration?
The surgeon must perform a meticulous manual palpation of the entire small bowel, running it between their thumb and forefinger from the ligament of Treitz down to the ileocecal valve.
Why is visual inspection completely unacceptable?
Because midgut nets have a 50% multifocality rate. These synchronous primary tumors are often tiny, 2 or 3 millimeter submucosal nodules. They are completely invisible on the serosal surface and too small for a CT scan to detect. They feel like tiny hard seeds. If you don't manually feel the entire bowel, you will leave primary disease behind.
What about appendiceal nets? When is a simple appendectomy sufficient, and what criteria mandate a right hemicolectomy?
A simple appendectomy is curative if the tumor is less than 1 centimeter, located strictly at the apex, and is a low-grade G1 with no lymphovascular invasion.
And when do you go back in?
We mandate a formal oncological right hemicolectomy if the tumor exceeds 2 centimeters, due to the high risk of nodal spread. For tumors between 1 and 2 centimeters, we perform a hemicolectomy if there is mesoappendix invasion greater than 3 millimeters, if it's located at the base requiring margin clearance, or if it has intermediate to high-grade features.
Let us address an intraoperative surprise. You are operating on a midgut net. You encounter a massive desmoplastic mesenteric mass densely wrapping around the superior mesenteric artery. How do you manage this technically?
It's highly demanding. I must carefully incise the peritoneum over the mesenteric root and use sharp dissection to meticulously peel the rigid fibrotic tissue away from the adventitial layer of the SMA and SMV.
What if the encasement is circumferential and densely adherent over a long segment?
If complete en bloc resection would require sacrificing the entire blood supply to the midgut, which would leave the patient with catastrophic short bowel syndrome, we pivot to a debulking approach. I would remove as much of the mass as safely possible to relieve the mechanical kinking and resect only the segment of bowel that is irreversibly ischemic.
I am going to elevate the difficulty. Consider this scenario. A 28-week pregnant patient presents with acute midgut ischemia secondary to a desmoplastic net. You must operate. Methodically balance fetal viability, maternal life, the technical challenges, and the pharmacology.
This is an extreme emergency requiring a dual-team approach: surgical oncology and maternal-fetal medicine. Maternal hemodynamic stability is the absolute priority, as fetal survival depends on it.
Detail the physical positioning and surgical approach.
The patient must be placed with a left lateral tilt. A gravid uterus at 28 weeks will compress the inferior vena cava if she lies flat, causing maternal hypotension and instantly compromising placental perfusion. We need continuous fetal heart rate monitoring.
And the incision.
I will need a high midline laparotomy extending well above the umbilicus to access the mesenteric root, working delicately around the fundus of the uterus to avoid triggering uterine irritability.
What is the primary pharmacological danger here?
Precipitating a lethal carcinoid crisis during induction or physical manipulation of the tumor. The stress can cause a massive release of vasoactive arenes, leading to refractory hypotension and acute fetal hypoxia.
How does the anesthetist prevent this?
They must administer a high-dose intravenous bolus of octreotide prior to induction and maintain a continuous infusion throughout the case. They must also strictly avoid any histamine-releasing anesthetic agents like morphine or atracurium.
Excellent. Surviving the operation is only half the battle. Section 5. Complications and prognosis. Detail the severe morbidities we anticipate post-operatively. Start with the bowel itself.
If we had to perform an extensive mesenteric resection, the patient will develop short bowel syndrome. This requires immediate total parenteral nutrition, TPN, to prevent malnutrition, followed by a highly monitored introduction of enteral feeding to stimulate mucosal adaptation in the remaining bowel.
What about intractable post-surgery diarrhea?
Highly common. It can be due to the loss of the ileocecal valve, which acts as a transit brake, or as bile acid malabsorption because we resected the terminal ileum where bile salts are recycled. Unabsorbed bile salts entering the colon act as a powerful laxative. We manage this with loperamide and bile acid sequestrants like cholestyramine.
Now, address the physiological management of a post-operative carcinoid crisis in the ICU. The patient's blood pressure crashes. What is the trap for the junior ICU doctor?
The trap is using standard vasopressors like epinephrine. In a carcinoid crisis, adrenal drugs will stimulate the tumor cells to dump even more hormones, paradoxically worsening the hypotension and potentially causing cardiac arrest.
So what is the life-saving intervention?
Rapid recognition, massive intravenous volume resuscitation, and an immediate high-dose IV bolus of octreotide to lock down the somatostatin receptors.
To prevent these intraoperative and post-operative cardiovascular disasters, what is the absolute preoperative optimization requirement?
A preoperative transthoracic echocardiogram is an absolute requirement for any metastatic midgut net patient to rule out carcinoid heart disease. If they have severe tricuspid regurgitation, the induction of anesthesia will cause right ventricular collapse. They may need an open heart valve replacement before we can safely resect the abdominal tumor.
I want you to simulate a Clavian-Dindo classification report. Let us say you operate on a 60-year-old with a terminal ileal net. She had previous heavy pelvic radiotherapy. You perform a resection and primary anastomosis. On day 5, she develops rigid peritonitis. A CT shows a frank anastomotic leak in the ischemic radiated bowel.
Right. Because this complication requires a definitive surgical intervention to treat, it is broadly a grade 3 complication.
Be specific. Which subclassification?
It is a grade 3 complication. The B suffix denotes that the required intervention must be performed under general anesthesia. I have to take her back to the theater, wash out the fecal peritonitis, and bring the bowel out as an end stoma because the radiated tissue will not heal.
Review long-term surveillance protocols based on ENETs. Timing of cross-sectional imaging for a resected midgut net.
Cross-sectional imaging, like a triple-phase CT or liver MRI, along with chromogranin A levels, should be performed every 3 to 6 months for the first year, and then every 6 to 12 months. This must continue for at least 10 years due to the indolent nature of the disease.
And what is the highly specific requirement for type I gastric nets? Why is it different?
Type I nets require regular esophagogastroduodenoscopy, OGD, every 1 to 2 years. This is because the underlying pathology is chronic autoimmune atrophic gastritis. The primary long-term threat to the patient's life isn't the neuroendocrine tumor. It's the insidious risk of developing a true aggressive gastric adenocarcinoma from that metaplastic background mucosa. we're surveilling for a second cancer.
Very good. We now move to Section 6, the final viva. We have 10 minutes. I'm going to fire several complex, overlapping clinical scenarios at you. These are killer questions testing your clinical judgment and ethical reasoning. Scenario 1, the immunocompromised patient. A 40-year-old patient known HIV positive with a poorly controlled CD4 count of 150. They present with a midgut mass and bulky mesenteric adenopathy on CT. You suspect a midgut net. You take them to theater for a right hemicolectomy. You send a piece of the nodal mass for a frozen section. The pathologist calls into theater and states, "This is not a neuroendocrine tumor. This is a high-grade lymphoma." Methodically explain your intraoperative pivot. Do you resect?
No, I absolutely do not resect. The intraoperative pivot must be immediate. The disease has shifted from a surgical target to a systemic medical disease requiring chemotherapy.
Why is completing the hemicolectomy wrong here?
Because a radical resection of a high-grade lymphoma in a profoundly immunocompromised patient with a CD4 of 150 is oncologically futile and surgically disastrous. Their immune system is too depleted to orchestrate wound healing. A bowel anastomosis would almost certainly leak, leading to fatal peritonitis.
So what exactly do you do in the abdomen before you close?
My objective shifts to securing high-quality tissue for the hematopathologists. A frozen section isn't enough for lymphoma subtyping. I will perform a generous excisional biopsy of a mesenteric lymph node to preserve cellular architecture for flow cytometry. I will confirm there is no impending bowel perforation, ensure complete hemostasis, and close the abdomen swiftly to minimize surgical trauma.
And postoperatively?
Expedite an urgent referral to hemato-oncology for systemic antiretroviral therapy and multi-agent chemotherapy. They need to recover quickly from my surgery so the medical treatment can begin.
Correct. Scenario 2, the anticoagulated patient. A 65-year-old on a direct oral anticoagulant, specifically apixaban, for atrial fibrillation. They present with acute, massive lower GI bleeding. Colonoscopy shows a 3-centimeter colonic net in the descending colon, actively, pulsatively bleeding. Endoscopic control fails. You must perform a semi-urgent segmental colectomy. Exhaustively detail the perioperative bridging strategy.
This is a balance between exsanguination and a fatal cardioembolic stroke. Given the 3-centimeter size, it mandates a formal oncologic segmental colectomy with lymphadenectomy. I cannot operate while they're fully anticoagulated on apixaban.
So how do you reverse it? You cannot wait for the drug's half-life.
I will order the immediate administration of andexanet alpha. This acts as a decoy receptor to rapidly bind and neutralize the circulating apixaban. If that is unavailable, a 4-factor prothrombin complex concentrate, or PCC, must be used to overwhelm the blockade.
Once reversed and stabilized, you operate. What happens post-operatively regarding the stroke risk?
Once surgical hemostasis is absolutely assured, usually 24 to 48 hours post-operator, I cannot immediately restart the oral DOAC because the fresh colonic anastomosis will bleed. I will initiate a bridging strategy using prophylactic low-dose, low-molecular weight heparin injections.
When do you restart the DOAC?
We step up the heparin cautiously, and the oral DOAC is generally not restarted until the bowel anastomosis has biologically healed, typically 7 to 14 days postoperatively, following a consensus discussion with cardiology.
Scenario 3. This is an ethical dilemma. The UK has a liver transplant program for net liver metastases. You are before the ethics committee. Livers are severely limited. Patients with benign cirrhosis die on the wait list. How do you justify allocating an organ to a patient with metastatic cancer? Explain the strict criteria.
The justification hinges entirely on survival utility. We must prove this specific cohort will achieve long-term survival comparable to benign indications. To ensure this, the inclusion criteria are inflexible.
Detail them.
First, complete prior surgical clearance of the primary intestinal tumor. Second, complete absence of any extrahepatic disease confirmed by a totally negative SSA PET scan outside the liver.
What about tumor biology?
The histology must be a well-differentiated low-grade net. Poorly differentiated NECs and G3 nets are strictly excluded. The Chi-67 proliferation index must be exceptionally low, typically under 5%.
And pre-transplant observation.
The patient must demonstrate documented disease stability over a mandatory observation period of at least 6 months. We must prove the biology is indolent. Finally, the hepatic burden must be unresectable by standard liver surgery, but not so massive that it physically precludes the transplant.
Does the beta support this?
Yes. When these rigid criteria are applied, the 5-year survival rates post-transplant exceed 70 to 80%, which is ethically equivalent to transplants for alcoholic cirrhosis. We are maximizing the utility of the scarce organ by offering a durable cure or decades-long life extension to a highly selected phenotype.
Stop there. That concludes the mock viva. You've performed adequately across all domains.
Thank you.
Before we formally adjourn, I want to leave a final provocative thought for the observing trainee listening today. Throughout this exhaustive review, we have relied heavily on manual, tactile realities. The absolute necessity of running the bowel between your fingers to find submucosal seeds, relying on physical staging, but oncology is undergoing a molecular revolution. Consider circulating tumor DNA and liquid biopsies, like the NEATest. This blood test measures neuroendocrine-specific gene expression with over 90% accuracy, providing real-time molecular assessment of tumor volume. I want you to consider the implications. As these liquid biopsies become standard, capable of detecting microscopic recurrence long before a PT scan lights up, will the operative technicalities we debated today become obsolete? Will the physical act of surgical staging be replaced by a peripheral blood draw? It is a question that will redefine the surgical profession in the coming decade. We are officially concluded.